presentation from Pakistan, famous spinal specialist, surgeon, and researchman, Tariq Sohail.
Good morning, Professor Radishenko.
Good morning, Tariq.
Good morning. Thank you very much for giving me opportunity to speak on this August
Glad to see you.
gathering. I understand that it's a huge dedication on your part and also the part of the participants and the contributors that even during this hard times, they are there and they're continuing their academic activities and academic pursuit. Can I share? Can I start?
Yeah, you can start.
Or you want to have
You
a
can start.
recorded?
We are ready. Yeah. Are you ready? Yes.
Okay. Yes.
Okay.
Thank you once again. As you know, the evolution of minimal invasive surgery of spine, it has progressed from the large incision to the very smaller, and from the very upper to the tubular to the percutaneous, and then there have been expandable retractors and loops, and ultimately end up in endoscopic surgery, which is, I think, very common and very popular in all over the world, especially in Europe and in the Far East countries, and it is getting popular in states as well. It is it has gone from the monoportal to the uniportal and the duoportal technique, in which you can address all the pathologies from the posterior side. But I think there's also good opportunity and good benefit from the transfemoral approach as well. And if you look at the historical context, the advantage of the minimal invasive surgery, low morbidity, less pain, and a faster recovery. And there have been various authors and contributors from the John McCulloch, starting from the microdiscectomy technique to the dedicated retractor system under microscope, and ultimately Kevin Foley with the tubular retractor system. They remain as a gold standard. They only give you minimal dissection, and there is no collateral damage, and you can address the pathology in a very focused manner, and you can have a minimal sort of damage to the muscle or the innervation or imbalance into the tension band principle of the spine biomechanics. The percutaneous treatment has been commonplace in many surgical specialties, especially the general surgery. Kambin from USA and Hajikata from Japan, they were sort of describe various systems, the needles and cannula, to target the safe entry into the spinal canal through the transfemoral approach, and which is mainly from the Kambin's triangle, which is a reasonably safe triangle to enter and to operate through the transfemoral approach. And percutaneous endoscopic has a assisted discectomy has been in the vogue and has been practiced since 1990s, and it's a fairly standardized and fairly a safe technique to remove the disc and to institute fusion or address any instability in this approach. Young's from states from the Phoenix, Arizona, he described the Young's endoscopic spine surgery system, which is fully functional endoscopic discectomy system. It's a multi-channel 7 millimeter endoscope with working channels. It has various dedicated dilators, reamers, and various other instruments, and they have been further refined and diversified by Hoogland, Rutan, and Sangoli in this field. And the idea is to provide versatility, provide safety, and provide minimal collateral damage to do the endoscopic discectomy through the transfemoral approach. At the same time, to address any instability and give sort of transfemoral endoscopic fusion with using the same kind of instruments and approach. These are various companies which make very elegant instruments which are very functional and gives you very satisfying results. And These are the diagnostic indications: degeneration, stenosis, instability, and prolapse intervertebral disc. And then through these approach, you can use execute discectomy, decompression, foraminotomy, and transfemoral lumbar interbody fusion. You can use these indication can be addressed mainly from the both posterior approach and the femoral approach. To my mind, I think transfemoral approach is much safer, much more elegant, and much more minimally invasive as compared to the posterior approach. Huh? And you can use interlaminar approach in which you violate these multifidus muscles, whereas the transfemoral approach, you don't damage any muscles or any tissue. These are the cadaveric dissection, giving a foraminal anatomy, normal left foramen L2 to S1. And you can see this the approach of the transference approach is very good. You can see the exit for traversing and exiting nerve root. You can see this disc level, and you can identify the disc, and you can enter into the disc with a multi-channel cannula, and you can remove the disc inside out technique, and you can also address various facet joint pathologies, and you can you remove the medial branch neurotomy, and you can take care of through this all approach from the foraminal approach, which is very evident from here. You can see various anatomical landmarks of the foraminal approach, which is called as a Kembin triangle, and it's a fairly safe triangle. Again, easier access to the disc from the posterior approach is equally good, but I think you have to take care of some part of lamina, maybe some part of facet joint, and you can then remove the ligamentum flavum and enter into the into the canal, and you can retract various neural element to approach the disc. It is still essentially similar to what the normal, but the approach is minimal. But I think the foraminal approach is much safer. You don't dissect away, and you can have a minimal risk of damage to any neurological element or tissues. These are the various schematic diagram of the Kembin triangle. It gives you a good amount of trapezoidal area, which is through which you can approach the intervertebral disc, and you can do various kind of discectomy, or you can institute fusion through the same approach. These are the anatomical specimen, which gives you various diameters, various dimensions of Kembin triangle at various levels, from the upper lumbar to the lower lumbar area. And that gives you good amount of area or access in which you can put various instruments, and you can use various telescopes, and you can approach this various pathology. Canonical approach is transclinical, which is, again, as I said, it's very similar to conventional discectomy, except that you remove minimal tissue and you remove minimal muscle insertion, and you can use various dilators, and there is a minimal collateral damage. But again, you have to remove ligamentum flavum, maybe a part of bone from the lamina, and then you can access. Whereas in the femoral approach, there is very little risk of collateral damage to the exiting or the traversing nerve root, and you can easily enter into the disc, and you can remove the disc from inside out technique, and you can address various pathology as well. Apart from that, you can also remove, annual ligament, and that gives you good access. At the same time, you can also give a foraminal decompression through the same approach, and you can, if you see the spinous stenosis, the one element of stenotic element in elderly patient is ossified formation, which is mainly at the exit foramen, and you can address this foraminal stenosis quite efficiently through the same approach, and you can decompress the exiting nerve root, and you can decompress the said or the affected level through the same approach without collateral damage, without producing any instability, and you can relieve the symptom. And this is very effective and good way to address in a patient who are elderly, who has other comorbid conditions, and you can address it under local anesthesia, and it gives you a good effective relief in this patient. The extra foraminal herniation of nuclear purposes, I think various studies by Ganchoi and Jan, it gives you good success rate of between something 86 to 92%, and a lot of patients doesn't need any repeat surgery or any other additional surgery in subsequent time of follow-up, and it gives you good symptomatic relief and good sort of functional outcome using these extraforaminal or foraminal herniation of nuclear purposes through the transforaminal approach. As I said, that foraminoplasty can be executed through the same approach in to remove osteophyte formation, which is causing stenosis of the exit foramen, and where the impingement of the root can be easily sort of taken care. Foraminoplasty gives you good clinical improvement both in any kind of score. And there are a lot of patients from 73 to 79% have a good, excellent result, ODI and VS score. And they give you a good sort of lasting result in decompression and relief of impingement of the exiting nerve root. And it does not induce any further instability and does not need any further instrumentation in most of the patient in which the dynamic pictures preoperatively doesn't show there is any preoperative instability. So I think in a situation where there is osteophyte formation at the exit foramen, you can you can expect a good result from foraminoplasty and get you good relief of symptom in these patients. Annuloplasty, I think that can be done. This is one of the very common conditions in which the annular tear is there, and there is a granulation tissue which appears as a white spot in the annular tear, and you can ablate it with a thermal probe, and it gives you good relief without any additional surgery. Other indications technique is central paracentral disc herniation, discitis, recurrent disc herniation, and you can address medial branch of the facet joint ablation, which is a main source of pain generated in elderly patient with a degenerative arthritis. And you can also use a similar, technique, not transforaminal, but interlaminar technique for discectomy, laminectomy for stenosis, or instrumentation for the fusion. So at times you have to combine both interlaminar and the transforaminal approach, depending on the pathology which you need to address. But especially in the L5 and S1, the posterior approach is much more effective as compared to the transforaminal because of high iliac crest, which impedes your approach to the L5S1. And you can execute all these techniques through the minimal approach through the L5, to the posterior interlaminar approach. Dual portal endoscopy, this is new. It is decouples the endoscopic camera from the surgical instruments. You can have a workflow similar to posterior approach. It's a low learning curve. If all the orthopedic surgeons doing spine surgery, they are familiar with the arthroscopy, and they can have a good sort of dexterity with the hands, and they can manipulate it quite easily. There are two separate portals for the instrumentation and also for the visualization, and gives you good sort of definition and you can have a various kind of pathology you can address through the posterior approach. It is indications and technique, the little recess or the central canal decompression at any level can be done, and especially in the elderly patient, I think it gives you good access and remove the ligamentum flavum and the central sort of stenosis, which can be addressed quite effectively. It can be used for the unilateral approach for the bilateral decompression or posterior lumbar interbody fusion, where you can you can use instrumentation and decompression at the same time, and one can easily convert microscopic access if needed to. So if there any problem there, you can easily convert it to microscopic, or you can convert it to open if required. The biportal endoscopic surgery versus microscopic gives you good improved result in both. There's no difference in pain scale and disability index, and the similar operative time and the shorter length of stay with a dual portal endoscopy. And there is a similar extent of decompression and similar complication profile. So I think it's just where you don't have any microscope, or if you're not familiar with the microscope, and you can use this biportal endoscopic technique. And the complication, they are a little unique to this. There may be ergonomics problems, there may be a fluid management problem, occasionally there's a bleeding problem, which can be taken care by the surgical band. And you can use endoscopic sort of diathermy technique, and access planning and the trajectory is important. That can be planned according to the pathology which you need to be addressed, and the endoscopic instruments, they are not too many, and you can easily sort of address most of the pathology the same problem. But sometimes instruments, they are not adequate, then you land into a problem. Post-operative complications, they are usual in any endoscopic technique, especially dual tear and etc. If that occurs, that can be taken care. Either you leave it alone, because in the endoscopic technique, it appears larger, but you can use various kind of glues through the same technique, and you can take care of any potential or apparent dual tear. General, apart from any spinal, you can have a reherniation, derotomy, neural injury can be there, vascular injury, infection. Infection is very little, but vascular injury, not vascular injury as such, but I think the excessive bleeding can occur through the intermuscular area or to the myo-osseous attachment, where the few vessels into the paraspinal muscles, they are there, and they can bleed sometime. So dual-portal endoscopy gives you versatile and powerful technique. It enhanced visualization and spinal anatomy is one of the virtues of this technique. Endoscopic technique has advanced recently, and they are easily to adopt, because most of the orthopedic surgeons, they are very versed with the arthroscopic technique, and it is very similar in its execution. And you can have an application to a wide variety of lumbar conditions, including lumbar fusion, and a similar outcome to the minimal invasive technique, but it's just another sort of facet of minimal invasive technique, from the transfemoral to the interlaminar to the biportal or the uniportal technique. So it's the idea of any minimal invasive surgery is that you do not cause a lot of collateral damage. Your patient is up and about and pain-free and going back to the work as soon as possible. So depending on the pathology, you can address it as transfemoral, you can use interlaminar, or you can use monoportal or dual portal spine surgery. So I think over the period, this endoscopic spine surgery platform is growing, and it has grown over the period of time. It has grown from the Haji Carter's days, we use arthroscope to do the discectomy, and from that level, and the Kimben's triangle has been sort of described and adopted very effectively by, which has been described by Parvez Kimbin, and that is a very useful portal to address most of the disc pathologies. And then posterior approach gives you good access to if you have any problem with the transfemoral. Then you can use not only spinal decompression in central, but also you can institute vision through the posterior approach, which is both interlaminar, and you can use biportal technique, and gives you a good treatment option. And you can use this technique for most of the spinal pathology in any given situation. The MIS advantage is that you can use in elderly patient with a lot of morbidities like diabetes, hypertension, cardiac problem, and occasionally you don't have to give anesthesia. You can use it under local anesthesia, especially the transfemoral technique. Thank you very much indeed. Any question?
Have a question to Tariq Sohail?
Yeah, thank you.
No? Thank you very much, Tariq. Glad to see you.